This is a surgical video demonstrating total correction of tetralogy of fallow in a 5-month, 5 kg old infant. A median sternotomy has been performed, thymus has been partially resected, and a pericardial patch is cleared for future usage. Pericardial stay sutures are placed, heparin is administered, and the main pulmonary artery is mobilized till the bifurcation. Stay sutures are taken on the main pulmonary artery and also on the ventricle for marking as well as future ventriculotomy. The SVC is mobilized, a snare is passed, and purse string sutures are taken on the aorta and then on the superior vena cava for cannulation. The aorta is cannulated and then the superior vena cava is cannulated with an angled venous cannula. Cardiopulmonary bypass is instituted and the IVC cannula is then put. The patient is now on total cardiopulmonary bypass. Purse string suture is taken in the ascending aorta for delivery of cardioplegia. Our choice of cardioplegia is del nido cardioplegia. The aorta is cross clamped and antegrade cardioplegia is delivered. The heart has arrested. The right atrium is opened parallel to the atrioventricular groove. The foramen ovale is dilated and a vent is placed in the left side. Attention is now focused on the pulmonary artery, which is opened longitudinally. The pulmonary valve is inspected and distal branch PAs are assessed with appropriately sized Hagar dilator and a vent is placed in the pulmonary artery. Stay sutures are then placed on the right atrium. It is important to use stay sutures in infant tetralogy repair to reduce the retraction to expose the structures. We can see there is a large subaortic VSD. The next step is resection of RVOT muscle bundles. The hypertrophied parietal band is hooked with a right angle forceps and then, as we can see, is being divided. It is also important to take a chunk of the muscle away after division to open the RVOT completely. All the parietal wall muscle bundles are then resected. We should be able to see the pulmonary valve through the right atrium after sufficient resection. At the same time, it is important not to resect on the septal side. In this case, the pulmonary artery is further opened. The pulmonary valve was very dysplastic and is being excised. It is a choice to use a monocusp or a bicuspid valve in RVOT in future reconstruction. In this particular case, a transannular patch was done without any valve. The ventriculotomy is extended. Any further muscle bundles are then resected through the ventriculotomy. It is also important to limit the size of the ventriculotomy to minimum to avoid post-operative right ventricular dysfunction. The orientation of the video has changed and you can see the cranial and the caudal end. This is the video from the top. Any further muscle bundles are resected and the RVOT is assessed visually as well as with an appropriately sized Hagar dilator to see whether the RVOT is open or not. The next step is VSD closure. The VSD in a tetralogy of fallow is a large non-restrictive VSD and our choice of VSD closure is interrupted 5-0 polypropylene pledgeted sutures. Multiple polypropylene pledgeted sutures are then sequentially passed through the VSD margin. At this stage also, retraction should be minimum as retraction leads to genesis of various arrhythmias in the postoperative period as well as low cardiac output syndrome. The assistant has to be aware of this. Multiple interrupted pleated sutures are passed through the VSD margin. At this stage, we are taking the sutures through the posterior-inferior margin of the VSD, and we have to be conscious of the bundle. The inlet portion of the VSD will be tackled later. An appropriately sized VSD patch is then fashioned. As I said, the VSD in tetralogy is a large unrestricted VSD, and the diameter of the patch roughly corresponds to the diameter of the ascending aorta. The VSD sutures are then sequentially passed through the VSD patch in an equidistant fashion. All the sutures have now been passed, barring the tricuspid inlet portion. In our technique of VSD closure, the tricuspid inlet portion of the VSD is closed with outside in sutures through the patch, through the tricuspid annulus, and then the needle is passed through a pericardial strip which is still attached at this stage and will be subsequently dismembered. Sequentially, the inlet portion of the VSD near the tricuspid annulus, the sutures are taken outside in fashion and then through a pericardial strip. The pericardial strip is then disattached and is lowered down onto the tricuspid valve, which acts as a pledget now. The VSD patch is then lowered and sutures are sequentially tied without using excessive force to close the VSD securely. Again, at this stage, retraction should be minimum. All the sutures are sequentially tied. The VSD closure is now complete. A visual inspection of the entire patch is done, and the focus is now shifted onto reconstruction of the RVOT. This is again a view from the top, and the cranial and the caudal end in the videos are marked. The RVOT is assessed with an appropriately sized Hagar dilator. We can see the VSD patch through the ventriculotomy, and an appropriately sized autologous untreated pericardial patch is fashioned to augment the right ventricular outflow tract. In this particular case, we did not use any valve in the RVOT. The transannular patch is then sutured with 6-0 polypropylene suture in a continuous fashion. It is important to place equidistant sutures on the right ventricular outflow tract for hemostatic suture line. The pericardial patch width should be just adequate without being excessively redundant. At the same time, it should not be too tight. The RVOT patch is nearing its completion. These sutures are being taken through the ventriculotomy. It is important to transition from the pulmonary artery to the muscular edge of the ventriculotomy carefully. The patch on the RVOT is now complete. The tricuspid valve is assessed and the PFO is then closed with a single polypropylene suture after de-airing. The cross clamp has been released, the heart has started to beat, and at this stage the right atrium is closed in a single layer with 6-0 polypropylene sutures. Patient is gradually separated from cardiopulmonary bypass, and then a detailed transesophageal echocardiogram is done to assess the repair. We can see the patient is in sinus rhythm with good hemodynamics and the TEE is being performed. This is the four-chamber view showing both the atrioventricular valves. This is the view to assess the RVOT in the longitudinal axis. The VSD patch we can see is intact. This is the longitudinal view to assess the LVOT, the VSD patch as well as the aortic valve. The gradient across the RVOT is also assessed. The patient is in good hemodynamic condition in sinus rhythm. This video demonstrates total correction for infant tetralogy of fallot. Thank you for your attention.